Sunilji.
We are live.
Good evening, everyone. Welcome to iFocus Online. Today is our lecture 115 and the glaucoma session is 19. And today we have with us Dr. V. Shantha, and she will be talking on glaucomas associated with disorders of the retina, vitreous and choroid, and neovascular glaucoma. And I request Dr. Vanita Patakre to please introduce Dr. V. Shantha.
Thank you very much, Rolika. And as usual, it's my great pleasure to introduce our guest faculty today. Before I do that, I just wanted to say that if we have time at the end of her lecture today, then I will give an update on the carotid massage as we discussed in the last module, number 18. And also I will give an update on that patient, the myopic patient who had bilateral angle closure disease and how I managed it. Right, back to business here today. Dr. Shantha is a senior consultant at Shankar Nethralaya. We all know that. She was also formerly the director of the Department of Glaucoma. She got her MBBS degree from Stanley Medical College, Madras, she calls it, erstwhile Madras, now Chennai. And she got a gold medal in obstetrics and gynecology in the bargain. She did her diploma in ophthalmology from Tiruchirappalli and her DNB from CMC Vellore. She has done various observerships with none less than Drs. Robert Stamper, Dr. Roy Wilson, Dr. Rand Allingham, and Dr. Robert Rich, a very envious list of glaucomatologists around the world, mostly in America, actually. She has several Best Paper awards at various fora. She has been the principal investigator for several clinical drug trials and has presented her research work at various national and international conferences, and we've all had the privilege to hear her. She's got over 45 publications in reputed journals, national and international. She also has been, she has also held the post of Secretary of the Glaucoma Society of India in the past. And of course, she, training of DNBs and fellows goes hand in hand at Shankar Nethralaya, and she has trained several such ophthalmologists, budding ophthalmologists. She has also conducted instruction courses, both national and international, at the AAO, at the World Ophthalmic Conference, at GSI, at AIOC, you name it. And she's also a reviewer of both national and international journals. With these words, I request Dr. P. Shantha to deliver her lecture today. Team CFS welcomes you and want to hear about glaucomas associated with the retina, vitreous, choroid, with special reference towards neovascular glaucoma. Dr. Shantha.
Thank you. And thank you so much for giving me this opportunity to be with you all. So we'll start off my talk. It's a very vast topic, so since I'm addressing postgraduates, I thought I'd confine myself to the more common disorders. So the most common one is neovascular glaucoma, and the second one is glaucoma secondary to retinal detachment or its treatment, which is more frequent, choroidal effusion, choroidal hemorrhage, and retinopathy of prematurity with secondary glaucoma. There are multiple causes for neovascular glaucoma. I will not go into the details of each, but the most common causes are diabetic retinopathy, retinal vein occlusion, and ocular ischemic syndrome. The others are less frequent, but they all share the final common pathway. These are causes for neovascular glaucoma as well, following irritation, tumors, inflammations, post-operative, and extraocular disease. So these are the mechanisms of neovascularization. The systemic conditions that I spoke about, or the ocular conditions and extraocular conditions, ultimately result in retinal hypoxia. And this causes the release of angiogenesis factors, which diffuse into the anterior segment, result in the formation of new vessels on the iris and the angle, which ultimately results in neovascular glaucoma. So you have a preclinical stage where you get rubeosis around the pupillary margin. If a peripheral iridectomy is present, you can get rubeosis around that area as well. It's important to do a gonioscopy to identify the new vessels in the angle. This is at the open angle stage, but ultimately this fibrovascular tissue contracts and you can get angle closure. This is an illustrated patient, an 80-year-old male who had multiple systemic issues. The left eye had poor vision with 636. IOP was 40 on 3 medications. He was pseudophakic with proliferative diabetic retinopathy and had already undergone treatment elsewhere. So on slit lamp examination, there was rubeosis, a little difficult to see on this photograph here, but you can see that gonioscopy shows new vessels of the iris. So how would we go on with management? Now, it has to be a team approach. First, it's important to look for NVI and a good magnification. Otherwise, you will miss it. And our optometrists are pretty good at picking this up. Gonioscopy is important. So it's important to do a comprehensive eye evaluation in all those who have these predisposing diseases. And as I said, the treatment is a team approach. First, you have to make sure that the systemic condition is taken care of. Quite frequently, you see a lot of work being done, PRP being performed, while the patient's blood sugars are around 400 to 600. So that's not right. Get the systemic issue dealt with side by side. If there are medio-opacities which preclude PRP, then fast panel vitrectomy with the removal of the lens, maybe with phacoemulsification, IOL implantation, or lensectomy, along with endo laser and vitrectomy. If the visual prognosis is poor, then we resort to cryoablation and diopexy. So for the IOP control, we start off with ocular hypotensive medications. We try to avoid PJ analogs at the acute stage. Myotics are definitely contraindicated. Topical steroids and cycloplegics are used to give some comfort. If the IOP remains uncontrolled, then a surgical procedure has to be done. Along with this, adjunctive treatment is the use of anti-VEGF injections. They are injected intravitreally, and this reduces the new vessels in the iris and angle and reduces the complication rate if surgery is performed. So the use of anti-VEGF is mainly complementary before any definitive treatment is taken. So clinical stage is important. As I said, a comprehensive eye exam has to be done for all patients who are likely to develop this problem. In the incipient stage, we have elevated IOP in open angles. NVI and NVA may be present. This goes on to open angle glaucoma with NVA and then ultimately angle closure. So depending on the stage and depending on the condition, investigations with the eye and systemic investigations are done and appropriate treatment is given. So the APGC guidelines for neovascular glaucomas start off with diagnosing the underlying cause, treating the underlying cause, as I'd mentioned, identify the mechanism, if it's open angle or angle closure, treat the mechanism, and medical therapy, as I had said. If this fails, then surgery is resorted to. The surgery has to follow the definitive treatment of panretinal photocoagulation with injection of anti-VEGF factors. So this reduces the formation of new vessels. Otherwise, this kind of complication with the hyphema occurs in the postoperative period, and that will lead to failure. So the results of neovascular trabeculectomy neovascular glaucoma are initially fairly all right, around 60 to 70%, but decreases over a period of time. So in pseudophakic and aphakic eyes, trabeculectomy doesn't work very well, so we have to use shunt surgery. All these implants have been tried. Again, initially they have fairly good success rates, but over a period of time, the effect goes down. So in eyes with poor visual prognosis, cyclophotocoagulation is done. But because of the risk of hypotony, one has to be careful with the amount of cyclophotocoagulation being provided. Central retinal vein occlusion is the second issue that commonly causes NVG. We have to remember that's associated with pre-existing open angle glaucoma, at least 20%, but it's also been noted to occur with the primary angle closure disease. And this is important to know because sometimes the eye with the acute CRVO can have a little lower IOP than the fellow eye. And over a period of time, these patients go on to develop elevated IOP due to the development of rubeosis. So angle closure glaucoma can occur because of ciliary body edema, which causes anti-rotation of the ciliary body and angle closure. If it's associated with primary angle closure disease, and an iridotomy is the first line of treatment, followed by the rest of the treatment protocol, as I had described earlier. Ocular ischemic syndrome is the third most common cause. You get ischemia of the anterior and posterior segment. It usually occurs in older people, more frequently in males. The presenting intraocular pressure in eyes with neovascular glaucoma can start off as normal. And this is the peculiar feature of ocular ischemic syndrome because of the hypoxia of the ciliary body. You get scattered retinal hemorrhages, narrowing of the retinal vessels, widening of the veins, cherry red spot, and ischemic optic neuropathy. Carotid artery obstruction is seen in more than 90%, and systemic diseases are commonly present. So asymmetric diabetic retinopathy is one of the clues for ocular ischemic syndrome. The eye with the carotid artery obstruction, the ipsilateral side usually has a significant retinopathy. The other eye might almost appear normal. These are the investigations which are done and show characteristic changes as I've described. So treatment of underlying disease is important, and it's important to tell patients that once a carotid endarterectomy is done, when ciliary body recovers, you can have a sudden elevation of intraocular pressure. Glaucoma is associated with retinal detachment as well, either due to pre-existing open-angle glaucoma, SCHWARTZ syndrome, where you get outer retinal photoreceptors which clog the drainage pathways, steroid-induced following the treatment, pre-op and post-op, trauma, which causes angle recession and subluxated lenses, ghost cell glaucoma due to an old vitreous hemorrhage, and could be surgery-related. We described the intraocular pressure outcomes following surgery for RHEGMATOGENOUS retinal detachment in SCHWARTZ syndrome. And 32 eyes were followed up for a median of 15 months. 41% achieved IOP control without intervention with just reattachment of the retina. 34% needed medication and 12% needed surgery. So it's important to follow up these patients as well. What about glaucoma following vitreoretinal surgery? This is one of the most common glaucomas that we see. The challenges are difficulties in IOP measurement because of the low ocular rigidity following vitrectomy. Investigations, there are difficulties in visual field interpretation because of the retinal pathology, and there are difficulties in management. The challenges are the poor visual potential, which may be associated, but quite often with the current treatment protocols, the visual acuity is quite good. You have a number of surgeries which involve conjunctival dissection. The concomitant procedures need to be performed. There are factors which promote neovascularization, which have to be taken care of, and there's always a risk of phthisis. So the etiology of elevation intraocular pressure could be either open angle or angle closure. Angle closure follows scleral buckling, and most often what happens is you get supraciliary effusion and ciliary body edema with anterior rotation of the ciliary body, forward movement of the lens iris diaphragm, a very shallow anterior chamber with increase in IOP. And these are the predisposing factors, especially pre-existing narrow angles, use of an encircling implant, etc. So medical management usually works. Aquasuppressants, cycloplegics, and topical systemic steroids. These drugs are contraindicated. If medical therapy fails, then laser iridoplasty usually helps. But quite often we require surgery in these eyes to take care of elevated IOP. So the problems are because of the conjunctival scarring caused by the surgery, conjunctival recession from the limbus, and retinal hardware which cause a crowding effect. So initially this used to be taken care of by placing a tube in the fibrous capsule of the encircling band, with the other end inserted into the AC. Sirotti et al. Described this. The advantages were that there were no restricting device was needed and no additional hardware was required. However, distal occlusion occurred quite frequently. So trimmed barbelled and AGV implants were then used, but the concerns were that the long-term IOP control was poor because you were reducing the surface area. So now full-size implants, the barbell, the RD implant, and the AGV implants are now used. The advantages of the AGV is that it is the FP7 is flexible and thinner, has a sufficient surface area, and has a tapered profile for easy insertion. So we have described our results of using the AGV in eyes with pre-existing encirclage, the 12 eyes of 12 patients. The FP7 was used, and you can see that there's a good drop in intraocular pressure following the surgery, and number of medications as well. But complications can occur. It's extremely difficult to repair the conjunctiva following the placement of the valve. And in 2 cases with extensive conjunctival scarring, we had to make relaxing incisions, and amniotic membrane was used in 1 case. With vitrectomy, you can get multiple mechanisms causing elevation of IOP, most commonly silicone oil induced and steroid induced, or the pre-existing pathology which may affect the outflow pathways. This was a lecture given by Stanley Chang on open-angle glaucoma after vitrectomy. And there's a surprisingly high incidence. This is a secondary open-angle glaucoma. It can occur as much as 10 years later. It's more frequent with pseudophakic and aphakic eyes, occurs a little earlier in these eyes, and is said to occur because of increased oxidative stress to the TM due to elevated oxygen levels in vitrectomized eyes with absence of the anti-oxidative mechanisms from the lens and the vitreous. Glaucoma following gas tamponade is frequent, as high as 67% sometimes. It increases with increasing concentration of the gas used. There's a mechanical anterior displacement of the lens iris diaphragm and expansion of the gas in low atmospheric pressure. So it's important to instruct the patients to avoid flying. The pretty high danger of central retinal artery occlusion if expansion occurs. So management is use of aqueous suppressants. Make sure that the patient maintains the appropriate posture with head down almost for 16 hours per day, sometimes as long as 10 to 14 days. Avoid high altitude flying. In case of a pupillary block mechanism, a laser hydrotomy can be done. In the case of overfill, you may have to do a tapping of the gas, but this is a last resort. Glaucoma following silicone oil injections, again something pretty common, is low with higher viscosity silicone oils which are used now. Pre-existing glaucoma is frequently seen in this group. Diabetes and aphakia are the risk factors. So either you can get a pupillary block, which you can see the profile of the silicone oil on this UBM. And usually the inferior iridectomy, which is being done, gets blocked with fibrin or with blood. And this results in a pupillary block. So this can be managed with a surgical peripheral iridectomy. Associated problems can be there, pre-existing PAS, inflammation, but most frequently you get migration of emulsified oil into the angle, and this can produce chronic trabecular meshwork damage over a period of time, leading to a chronic secondary glaucoma. Sometimes the entire silicone oil bubble enters the anterior chamber, and you can visualize a shiny reflex on the surface of the iris. It's extremely important to identify this problem and deal with it. So most often, if surgical treatment is required, you combine it with the silicone oil removal. If the visual prognosis is poor, then laser treatment is done. If the visual prognosis is good, then either trabeculectomy with mitomycin C or drainage devices are used. This is a patient who underwent trabeculectomy with mitomycin C following scleral buckling, and in 5-year follow-up, he actually did not require medical treatment. So this is a surprising result, which is not that frequent. Failure is more common. And when we looked at our results of trabeculectomy with mitomycin C, the survival rates at 12 months was pretty good, but pretty poor by the end of 5 years. And these were some of the risk factors. GDDs are used more frequently. It's important to identify the quadrant in which you need to place it. If there are extensive PAS, you might have to place it through the pars plana. So this is a surgical video of a tube implant which I had performed. So you can see that there's extensive scarring caused by the earlier surgical procedure. So the incision has to be made beyond the area of scarring. And you can see the scleral pre-existing buckle here. You have to dissect the fibrous capsule which surrounds the buckle, and then place the Ahmed valve implant after priming it. Now, when you're suturing the implant, you have to be very careful because many of them have thin sclera and perforation is possible. So very careful suturing has to be done. If possible, bury the knots so that you don't get suture exposure. It's important to have an AC maintainer because these eyes are prone for choroidal hemorrhage, so maintain intraocular pressure. So the tube is inserted either into the anterior chamber or through the pars plana if required. If pars plana placement is done, you have to make sure that the vitreous base around the end of the tube has been excised. Otherwise, a vitreous block is possible. The tube is then anchored, then a scleral patch is placed over the tube. And then conjunctival closure is extremely difficult in these patients. It's important to identify the Tenon's capsule and suture it separately from the conjunctiva. Sometimes relaxing incisions may be required. If you feel that the wound healing is likely to be poor, you can put these patients on doxycycline which helps in healing. And sometimes a bandage contact lens will prevent excess rubbing of the eyelid movement over the incision site and will prevent wound dehiscence. So these are the factors that you have to take care of in GDDs for post-VR glaucoma. So if the visual prognosis is poor, then we resort to cyclodestructive procedures. The contraindications are if there's acute inflammation, thin sclera, or a deformed limbus. And the approaches can be transpupillary, transcleral, or endoscopic. The diode laser is more commonly used. Now the microdiode pulse laser is available, which has equal efficacy and better profile. These are the common side effects, but uncommon side effects are seen, especially sympathetic ophthalmia, which is now more common following intraocular surgery than trauma. Endoscopic photocoagulation can be done, can be combined with anterior segment surgery or with VR surgery. And the advantage is that you can see the entire ciliary process and observe the endpoint. So VR surgery is a known risk factor for glaucoma, and most cases can be managed with medical treatment. Glaucoma drainage devices are the most common surgical choice of therapy. ROP is another problem which we face now that we are treating more children with this disease. It's usually due to angle closure glaucoma due to movement of the lens iris diaphragm anteriorly, sometimes associated with trabecular dysgenesis in the form of anterior iris insertion. But open angle glaucomas have been described as well. So we looked at the outcomes of glaucoma surgery in these children. The number of eyes was not much, 15 eyes of 13 patients. Fortunately, most of them do well with laser treatment and surgery. We used external trabeculotomy with or without trabeculectomy, glaucoma drainage devices, or cyclophotocoagulation. And you can see that in the three groups, the preoperative data were quite similar. Post-operative complication rates were slightly more in the drainage devices group. And however, the success rates were slightly better in patients who underwent drainage devices, but the outcome is fairly poor in all these eyes, which occurs most commonly in stages 4 and 5, especially when lensectomy is done. So prevention is better than cure, especially in this young group where most of the children are a result of precious pregnancies. Choroidal hemorrhage is another devastating complication that we come across, and we have described the risk factors in a pediatric age group, but they are similar to those in adults. Sudden decompression of eyes with high preoperative IOP, hypotony during surgery, lower scleral rigidity as you see in congenital glaucomas, elderly age group, systemic hypertension, high myopes, aphakia, and vitrectomized eyes. These are some of the non-surgical causes of suprachoroidal hemorrhage that we have to be aware of, especially the systemic use of antithrombolytic drugs and anticoagulants. So when surgery is concerned, preoperatively reduce the IOP as much as possible, make sure that the systemic conditions are under good control, use adequate local anesthesia, avoid external pressure on the eye with a speculum, do a paracentesis if you need to lower the IOP gradually, and use an AC maintainer. The management is the use of aqueous suppressants with cycloplegics, topical and systemic steroids. A serial ultrasound is done to look for clot lysis, and once this occurs, the surgical drainage is done by the vitreoretinal team. Another interesting but very difficult condition to treat is nanophthalmus. And these are the features which were described by our pediatric ophthalmologist, Dr. Smita Agarkar, in the journal JPOS. And the most common problem is a small eye with a normal lens. So this results in a high lens-eye volume ratio and a thickened retina choroid scleral complex. So a representative case is a 58-year-old lady who came with gradual decrease in vision. She had come for a routine checkup. And this was her visual acuity. You can see the high hyperopic error and quite a dense cataract in both eyes. IOP was extremely high. The angle was completely closed. You can see that the axial length was really low with the normal lens thickness, and the lens thickness axial length ratio is characteristic. So you can see that this amount of cupping in a small disc is quite significant, and it had resulted in significant visual field loss in the left eye. Laser iridotomy was done and medical treatment was started. However, it remained uncontrolled. So she was taken up for surgery. We plan preventive sclerotomies and sclerectomies, and we have described this. Dr. Reverie, who was our fellow, has published this. And Arvind Eye Hospital has done a randomized control study where they randomized patients who received sclerotomies in one group and did not in the other group, and found that sclerotomies really make a difference. I'm sorry, my screen is not moving. So this is a video of combined surgery in an anophthalmic eye, along with cataract surgery and a trabeculectomy. So 360-degree peritomy was done. Then the muscles are hooked up all around. So the sclera is cauterized, and about 5 millimeters from the limbus, we make a scleral incision in the form of a square. The sclera is dissected out in order to thin it so that the pressure over the vortex veins is reduced. In the bed of this scleral dissection, we make a V-shaped incision, which is then raised. It is lifted off from the surface of the choroid, taking care not to injure it. And then, if required, we can even excise this bit of the sclera so that choroidal effusion, if it occurs intraoperatively and postoperatively, can drain and reduce the intraoperative positive pressure. The scleral flap is reopposed. Now, this can be done in the inferior 2 quadrants or in the all 4 quadrants if the axial length is really small. In eyes with an axial length of about 18 to 20 millimeters, sometimes you can just get away with the linear sclerotomy and choroidal drainage. So this was a postoperative picture. So in conclusion, in all conditions with the retinal problems causing secondary glaucoma, it's important to do a comprehensive eye evaluation so that you don't miss out early signs. Do a systemic evaluation and appropriate treatment. A multidisciplinary approach is required. Quite often you have to involve the cornea department, the pediatric ophthalmology department as well, and a long-term follow-up is needed. Thank you.
Thank you very much, Dr. Shantha. You really rushed through it. You actually had a little bit of time.
We heard, Vanita, that you have also
No, come on. I don't need 5 minutes.
Just joking, yeah.
So my attention span is not more than 20 minutes. So,
oh my God. No, you should have warned us then. Okay. I invite at this point Dr. Harsh and Dr. Pradeep with their impressions.
Oh, such a wonderful lecture. Absolutely beautifully given and very appropriate just for the postgraduates, because really one has to sometimes, some people get lost and give it for a GSI session, but this is truly for the postgraduates because she has been teaching. And I think for the postgraduates, yes, I think the most important thing that you will invariably face in the exam, either in the theory or in the practice, is neovascular glaucoma. So you will have to know what are the causes of neovascular glaucoma, and of the various causes, how exactly you will involve the retina person, or if you are in practice, then obviously you will have to deal with it yourself. So whether you have to first deal with the ischemic factor, do a peripheral PRP, then get rid of that thing, and then later, even if then the pressure doesn't get controlled, then yes, like Shantha told so beautifully, that you have to decide whether you go for a tube or a trap. And most of you would not be able to do the tube in practice, so you may just have to go for a trap. But if you are going for a trap, then you would have to put in an anti-VEGF injection around 2-3 days before you go in for a trap, so that the vessels are least present over there. And if you're doing a trap, sometimes if you still see the vessels, sometimes you can actually cauterize the area where you can do a peripheral iodopathy. As far as the retina part is concerned, very rightly she said, it may be very, very tricky to actually evaluate these cases, because retina is involved. So doing the fields and everything else becomes much more complicated. So sometimes you may just have to depend on the pressures, but maybe fundus photographs and a good disc evaluation would really. Prateep, please.
Yes, thank you, Shantha. It was really a wonderful talk, and it's a very difficult topic, even for us, not only for the PG students. And it's difficult to deliver the talk, and also it's very, very difficult to manage these patients. To save their vision is very difficult. And as you have covered the ROP patients as well, if you have a bachu with this problem, it's very difficult. I can tell you, you are sitting in an institute, you are managing these patients regularly. But for us, when we get very rarely, it's very difficult to manage, very difficult to put the ball. And post-op follow-up is also very difficult. And even in adult patient, it's very difficult to save the vision in these patients because in spite of the surgery, many of these patients, they continue to have a high intraocular pressure. Their vision is very poor because of the retinal condition. So to judge that whether the glaucoma is progressing sometimes becomes very challenging. So it's a really very challenging situation, not only the neovascular glaucoma, but all glaucoma associated with the VR disorder. And you have covered them very thoroughly. And I have seen many of your patients manage also diligently. So that's wonderful. Thank you very much, Shantha.
Thank you so much, sir.
Right, so there are a few questions. One is how to diagnose ocular ischemic syndrome before neovascular glaucoma develops?
Well, as I said, comprehensive eye evaluation in all these patients is important. Especially you have to do a systematic evaluation, IOP measurement, gonioscopy, and then the fundus picture. Quite frequently, before you see anything else, you see a lot of scattered retinal hemorrhages in the mid-periphery and changes in the caliber of the retinal arteries and veins. Sometimes they present with ischemic optic neuropathy, and it's usually, and in diabetic patients, as I said, that very asymmetric picture with the eye in which the carotid artery obstruction is more significant, you're likely to have a worse fundus picture, and the other eye might appear almost normal. So once you see these features, then you suspect that something else is going on. And as you go in for investigation like the FFA, you pick up the changes which occur, and then the systemic evaluation has to be done. So it's a systematic approach which has to be performed.
Right. And is anti-VEGF required in all cases? Will PRP not suffice? If you are faced with a patient who cannot afford, laser is definitely a lot more affordable. Can we not wait?
Yeah, quite frequently the PRP does take care of the rubiosis, and over a period of time, if the systemic condition has been controlled with PRP, with medical treatment, you've been able to control the IOP, then you have the luxury of waiting and then performing the surgery if the IOP remains elevated and this changes progress. But quite frequently, we don't have that luxury. The IOP is really high, the patient is in severe pain, all the appropriate treatment has been given, and you're forced to operate. When angry new vessels are there, there's just no point in operating because you're going to have a significant hyphema with its attendant complications. So anti-VEGF injections are not all that expensive now. If you have to perform surgery, the surgery is equally expensive. So it's better to give it intravitreally for about 4 or 5 days prior to the procedure, and then otherwise it's no use for the patient.
Yeah, that was the second part of that question is how long do you wait following anti-VEGF? The reasons I'm asking is all these questions actually also occurred in the recently concluded WGC. I attended a session on NVG, and these questions were around the world, there were different answers. How long do you wait?
I usually wait for at least 5 to 7 days. If there's signs of regression of the new vessels, it won't disappear completely in such a short time. But you can see that the angry appearance that you have seen initially starts subsiding. The inflammation comes down. The patient is more comfortable. At that time, it's fairly safe to intervene.
Right. Okay. Dr. Harsh, how long would you wait?
I think the answer is that you have to keep looking over there. But yes, it could be, the window could vary from 3 days to 7 days.
Yeah.
But most of the times what we want to do is the moment they disappear, like Shantha was rightly saying, we have to operate because they can't even see the cornea clearly and they can't do the PRP. And we want them to do the PRP. So the moment we operate, the pressure goes down, the things clear up, and then they can actually deal with the basic ischemic factor.
Dr. Pradeep?
Shantha, you tell me, yes, we will continue with that. But what do you think about the ARC? Because lots of the VJF come from the far periphery of the retina. And, it's very difficult to ablate these, and the new vessels keeps on coming in this patient. You keeps on giving the anti-VJF, and anti-VJF, in my opinion, is just like kind of a protein. You give the protein and the fever goes away. So once the effect is gone, then again they pop up. In the old time, we used to do lots of ARCs in this patient, and it's still occasionally, rarely, still I ask my retina person to do the ARC if they are not able to control. They have covered all the spaces of the retina wherever fill in PRP is possible, given multiple anti-VEGF injection, and still you keep on seeing the new vessels. So I asked them to do the ARC. What is the role of ARC? What do you say?
Yes, sir, definitely. There are situations where you get, very high IOPs, a cornea is edematous. It's difficult to treat, and it's difficult for us also to straight away go in and perform a surgery. The chance of complications are very high. So in such situations, we ask the retinal surgeon to do a anterior cryo. And sometimes you can even do a retinal diopexy with a diode CPC and perform a diode cyclophotocoagulation at the same time. We're just a little careful not to do too aggressive a therapy because they can go into phthisis. So definitely ARC has a role to play.
Okay. I find that ARC causes a lot of inflammation, too much chemosis. I am associated with a sister concern of Center for Sight, an institute called Retina now, and I do get all these glaucomas associated with the retina, retinal surgery, choroid, vitreous, you name it. So what I have started doing is doing very aggressive management of IOP, meaning if the patient presents to me, and usually they come from, from far distance. So on the day, I will control the pressure with mannitol if required, clear the cornea with mannitol with glycerol if required, clear the cornea, get my retina colleagues to do the PRP on the same day, get them to do an anti-VEGF within a few days of that, and then, if required, operate. I have found that managing glaucoma like this has resulted in much better outcomes. I will write this up at some point. I am getting a series of cases now, and patients are also very happy because they come with corneal edema with the pressure, with the vision of count fingers and with pain. Not only does the pain subside, but their vision improves quite a bit. So they're pretty happy.
The problem is that contact lens after that.
Sorry?
After you debride the cornea, do you give a contact lens after that?
No, I don't debride the cornea. The corneal edema subsides. Very often I have seen on the same day it subsides.
Most of the times it's not happening. That is
with glycerol as well on the same day.
So the more problem is that, many of these patients are very bad diabetics. And if you give a mannitol and glycerol to these patients where the kidney is already compromised and about there is a time off, it's a very difficult situation. If the patient lands in the ketoacidosis, then it's difficult to manage the ketoacidosis rather than the glaucoma part.
I agree. Diabetes, if sugar is not controlled, it's a big problem. But what I have seen is one dose really does not matter so much on the day, especially if, they can tolerate the fluid overload. The kidney disease is the most important. But so many times I find them coming to me with full dose of Diamox, no concern about, the kidney disease also. So, there are many factors which unfortunately confound your ultimate outcomes. But still, I would feel, this is what I'm trying to do now. I am trying to be very aggressive with it in terms of IOP management so that the retinal treatment can be done almost on the same day or the next day. And PRP, I believe, has a great role to play. Although everyone says 6 weeks, you have to wait 6 weeks. I have found you don't need to wait 6 weeks. Within a week, 2 weeks with aggressive PRP, meaning 2 sessions, 2,500 spots minimum, and an anti-VEGF. With glaucoma surgery, they do pretty well.
In one of the earlier talk, you mentioned about the endo-CPC. So probably the endo-CPC is very useful in some of these patients, particularly those patients are pseudophakic.
Yeah, exactly. When they are phakic, unfortunately, it has a limited role. And in pseudophakic eyes, I have found that in glaucomas like this, which are refractory and also tend to cause a lot of inflammation, it's probably not a good idea. So I don't venture into that just yet. I may try. I don't know. I never say never, but I feel that where inflammation is very much part and parcel of a disease, endo-CPC may not be that great an idea. And the transscleral, I suppose one does when one is more or less sure that the visual prognosis is poor.
Any difference, Shantha, between transscleral and the micropulse in these patients?
No, micropulse we haven't used personally. We have only the diode CPC, and we reserve that for really refractory cases. Most of the time with the initial protocols, the IOP does come under control, and we are able to perform either a trabeculectomy or a GDD for surgical control. And once the retina person takes care of the PRP, it does subside. It's very rare that we have to go in for an aggressive procedure. But once the eye becomes quiet, endo-CPC has been done by the retinal surgeons along with the vitrectomy for a vitreous hemorrhage. And surprisingly, they do quite well. The only issue is that if they're aggressive with the treatment, you get hypotony and phthisis. So you have to be very careful.
So with endo-CPC, you actually cannot target more than 2.5 quadrants. I don't know whether they do pars plana or not. They probably do pars plana.
Yes, the pars plana vitrectomy with we can't do more than 180 degrees because it's not safe.
Yeah. So hypotony actually with endo-CPC is pretty rare. I have not come across a single case so far, but I've not treated NVG with it. That's for sure. You did talk about that study where in the kids, you said that endo-CPC was also done. The third group.
This is in ROP. These are all eyes with very poor prognosis. So when multiple VR surgeries had been done, we were doing it more for comfort than for visual rehabilitation. At that time, endo-CPC was done along with the VR procedure.
Right. Okay. So in the session on NVG in the World Glaucoma Congress, the talk was about waiting at least a month before anti-VEGF, and I thought that was too long. You may start losing your effect. Then they qualified saying, okay, 2 weeks to a month. I don't know. I feel
it's very different from ours.
Yes.
Is it?
I think so, because there's no way that we can wait for 1 month and 6 weeks. Very frequently we have to intervene far earlier.
Yeah.
Especially in this scenario after COVID started, where diabetic.
Oh, absolutely.
So for a long time, things had got better, and we didn't have to take such heroic measures. But it's become very bad for the past 18 months.
You're quite right, actually. Well, there are no further questions unless our chair and co-chair have any.
I think we have discussed enough. We have learned a lot from Dr. Shantha. And obviously, yes, you also have contributed.
Oh, sorry, there is another question now, last minute. How to manage NVG with vitreous hemorrhage and poor media clarity?
Well, I think I had mentioned earlier, supposing you think the visual potential is going to be very poor, then we perform a ARC with or diopexy with diode CPC. Quite frequently, the IOP control improves, the clarity improves, and then more definitive treatment can be given. But most of the time, we leave it to the VR surgeon. They have to do a vitrectomy, a lensectomy if there are dense cataractous changes. If a lens removal is required, it may be difficult to perform a phacoemulsification with an IOL implantation. More frequently, lensectomy is done and the anterior capsule is left behind so that later you can, if the eye improves and the visual acuity is good, then a secondary IOL can be implanted. So it's a combined surgery which is required, and we have even combined it with the glaucoma drainage device at the same time, if we feel that long-term IOP control may be a problem. Because once cynical angle closure has occurred, then the retinal procedure alone won't be sufficient.
Okay. And another interesting fact, actually, just transposing it from the WGC session, there were, of course, speakers who talked about doing diode laser. There were speakers who talked about trabeculectomy. There were speakers who talked about drainage implants. But when a poll was taken as to what you would do as your first surgery for an NVG, the majority, not just the majority, all of them said GDD. So what is the consensus here?
One of the problems is, you see, who are these sessions being performed for? You see, if you are actually dealing with the vast majority of Indians, they are unable to perform a GDD. Okay, so we must keep all options and give them all the options, because most of the people would only be able to do a trabeculectomy. So we should define that, yes, these are the situations where you may do a trab after putting an injection and doing things like this. Because doing a GDD is very good for people sitting over there and everywhere. I think in the West, the GDD is the first thing they teach and the trab is the second thing they teach. And many of the time they don't even teach the trab. So for us, I think one has to be, like Shantha has already defined very clearly where one should go. Prateek?
Yeah, I agree that, most of the patients, they do require a GDD, but if you are not trained, then you don't have the option. But in my practice, almost in 50% of the patient, I would do GDD, and approximately 30% patients I do trab. And if you have selected the right patient for the trabeculectomy, they do well. And remaining 20%, I will do the cyclodystrectomy procedure. That is what my practice pattern is.
Shantha?
I think in phakic eyes, if everything else is all right, a trabeculectomy works quite well. But in a pseudophakic and aphakic eye, I would prefer an implant.
I would say that there is now a tsunami of pseudophakic diabetic eyes. Yes. I do not see any diabetic eye which is not pseudophakic. It is amazing. It is absolutely amazing. I perhaps have seen, done one or two in the past 5 years where I have taken the lens out also, and I've done, a phaco and taken the lens out and done a GDD, but the rest, all of them were pseudophakic, all of them. So, I feel. And I agree. I would go with the visual potential. If the visual potential is good, I think I would give GDD a chance. I also do a trabeculectomy. In fact, just 2 weeks ago, I did a trabeculectomy for an NVG. But if there is visual potential, I think my first choice is a GDD now. Right. So I think we've exhausted all the questions here. Thank you for the very lively discussion. It's always great to hear from you. We thank you for your time. Now in this section, I generally discuss a few things with the PGs, and it's sometimes rolling in the sense that I give an update. And today that is what I'm going to do. You're more than welcome to stay, but we will understand if you need to go. Thank you very much.
Thank you.
Bye, Shantha. Good night.
Thank you, sir. Good night.
Right. So I just wanted to talk about the carotid massage. I did find out from my husband, as I said, I will. The update on carotid massage. So it isn't the neurosurgeons who like it. It's actually the treatment of carotico-cavernous fistula is now almost exclusively interventional neuroradiologists who do it. And it is they who actually prefer this carotid massage. We all know carotid massage is actually meant for, or was originally described, I won't say meant for, originally described for tachycardias, mainly ventricular tachycardias. But with the carotid massage, it has been found that about 17 to 30% CCF can actually get better. So they prefer doing this initially under supervision, because as soon as you touch this area, as you know, you can get a bradycardia. So what they suggest is with your contralateral hand, not ipsilateral, never ipsilateral, you press on the side of the neck where you know the carotid is bifurcating, basically on your carotid sinus, and you press for 10 to 15 seconds and then release. And you do that 10 to 15 times a day. But of course, when you're pressing in front of under supervision, you monitor for bradycardia and things like that. What is also a possibility is that you can get a contralateral. If you reduce the blood supply to such an extent, you can get transient weakness on the other side. And if that is why you use your contralateral hand, so the hand will get weak and fall off. So that I thought was really clever, that you do never use the ipsilateral hand, you use the contralateral hand, and about 17 to 30%. So thank you very much, Dr. Meenakshi Dar, for bringing out this point. And I really loved
and thank you very much to you for explaining us how to do it.
Finding out more about it. And then it's the second one. This very week, I operated on that bilateral angle closure. If you remember, this lady who presented with bilateral angle closure, and within 2 days of controlling her pressure, she had become quietened down quite a bit. As you know, she was very, very shallow. And post PI also, she did not improve. And all her parameters, starting from anterior chamber depth, lens thickness, as well as her not her axial, other than axial length, they were very suggestive of a anterior segment sort of, the word now that is used is nanophthalmos, but her axial length was suggestive of myopia, and which she was a -10 myopia. So I don't want to talk about the details. You saw the dragging of the vessels, and she also had laser. This is her right eye, and you can see the laser marks. This was for lattice that was done 4 years ago. So this lady now, she underwent a Phaco Endocycloplasty, and I will just briefly show you the procedure. I'm really sorry, I don't have a recording device yet for my endocyclo photocoagulation. Plasty is when you just apply at the tip and see the ciliary process fall back. That was a pop which you need to avoid, and you immediately bring the power down. As and when you treat, the ciliary processes start look like dentate processes, like the teeth. You can see now how beautifully they are falling off from shrinking back. Not falling off, shrinking back. The best one perhaps is now, yes, where you can see it come back. All right. Once this was done, I will show you the intraoperative gonio pictures of this lady. This is prior to any intervention. Just when I started, before I started, you can see that I can't see any angle structures. After I had taken the cataract out, you can see the AC is much deeper. I hope you can make that out. That this is cortex was still there, yet I did not see any structures in the angle. This is all inferior angle. But when endocycloplasty was done, I started seeing some structures. It wasn't very clear because the IOP had become so low, the eye had become so soft. So I was always getting folds. So what I did was I inserted my endoscope into the anterior chamber. And lo and behold, can you see? This is your trabecular meshwork, and this is your scleral spur. There is some synecdoche still left, like here, but you can see how much the angle has opened up, almost like magic, almost like magic. Let's have a look at a closer look, a closer look at it. Have a look here. Where the call out is, you can now see trabecular meshwork, quite pigmented, and you can see scleral spur just behind it. This is scleral spur. This is trabecular meshwork. However, here you can't see angle structures. That is an area of peripheral anterior synecdoche. You can see the trabecular meshwork as well as the next to the area of pars, you can see the trabecular meshwork and scleral spur again, and that area is an area of pars. So on both sides of that pars, which is less than half a clock hour, if that, you can see widely open angle. Next day, she was 20/100 unaided. She was very happy. IOP of 12. Unfortunately, other eye IOP shot up again. Very soon, we will have to do the same procedure for her. You can see how deep the AC has become. There is a little bit of fibrin in the AC. That is not unusual. And you can see the other eye still being so shallow. So once I've done the other eye and I have further postoperative IOP and vision, I shall update you further. So that's it from me today. Again, we didn't have very many hot seaters, so I thought it is best just to update. I hope this update has been of some use to you guys. I only see Dr. Veer and Dr. Soni there. Hi guys, how are you?
We are fine, ma'am.
Fine, ma'am. Thank you, ma'am.
Update, ma'am.
Did you see? There was a question to me why I would like to do endocyclophotocoagulation. Well, the technique was just slightly tweaked, and this technique is known as endocycloplasty, where you target the tip of the ciliary process and you make it shrink away from the angle so that the angle opens up. So actually, you get instantaneous results if you can see it instantaneously when the angle opens up.
Yes.
Okay. So,
Yes,
so do you think she will benefit in the other eye as well? I think she will. She will probably not get much vision back in that eye because that has been the poorer eye. But having stabilized her only seeing eye, we will probably take up her other eye. Okay. So I think that's enough for today. We will have next week. We will have Dr. Gauri Murthy from Bangalore, who will talk to us about glaucomas that are associated with ocular inflammation. Okay.
Okay, ma'am.
Good night.
Thank you, ma'am. Good night, ma'am.
Good night.